Hi friends, I'm Dr. Pahuja. I'm the Chief Medical Officer for Aerolib Healthcare Solutions. And what we're trying to talk today is the $4 billion a year healthcare auditing basics in just one slide. So let's start. We have three blank canvases. In our first canvas, we have the hospital and the physicians, and obviously the patients that are being treated there. In our second, we have CMS or the government. And in the third is the private insurance companies. What we'd like to do is tell you that CMS introduced an auditing side a few years back. And they've always had auditing companies, but they've been in this traffic light pattern of how they relate to hospitals. So the bottom two that you see are the CERTs and the QIOs. These are the ones that help the hospitals. We have the RACs, or the recovery audit contractors, the Medicaid integrity contractors, and the Medicare administrative contractors, shortly known as the RACs, MICs, and MACs. These help in compliance oversight with the hospitals. The top three, the ZPICs, or the Zone Program Integrity Contractors, or the Office of Inspector General, and the Department of Justice. This is why they are red, because they are legal oversight organizations. Now, CMS, or the government, introduced the concept of RACs in 2008. Now, these were a pilot project for a few states, and what they did was recover about $300 million as part of fraud prevention. Now, that has increased to $1 billion a year when they rolled it out to all over the country. So what they do is RACs retain a percentage of what they audit. And that's a very unique model to have a contract with the government. Is the amount of money that they save, they keep, whether it's 9% or 12%. And so they're incentivized to find fraudulent billing or improper billing. Now, once this was rolled out to the entire country, the CMS divided them into 4 regions, and every year contracts are released. Companies bid for them, and they win this contract to do this auditing. In addition to the RACs from 2008, CMS started to introduce ICD-10 last year, and this is where specificity of documentation as well as the procedure codes for hospitals had changed. They came out with what we call the CMS 1599, and I'll talk about that in a few minutes, but a new law which guides hospitals on how to bill patients. EM audits, or evaluation and management audits, which actually describe the core level of service and the intensity of service. And in addition to the accountable care organizations, new changes in the QIOs, CERTs, RACs, MACs, MICs, ZPICs. HIPAA and HITECH came out, putting more pressure on hospitals to safeguard protected health information. Now, the payers as well as insurance companies followed suit to what CMS was doing, adding more administrative burden to the hospitals. Now, CMS introduced what I described earlier as the 2 midnight rule, or CMS 1599. Now, what that does is tell hospitals on whether patients should be an inpatient or an outpatient based on the duration of stay in the hospital. So say a patient or a Medicare beneficiary stayed for more than 2 midnights, CMS would pay an inpatient level of service, or the rate, which usually could range from about $12,000 per patient for that 2, 3, or 4 day history of stay. If this patient stayed less than 2 midnights, CMS decided that would be paid as an outpatient, which could be $4,000. So what was initially billed as complexity or the medical decision making by a physician was replaced by a time-based duration of stay of the patient at the facility. Now, very different. In addition to this 2 midnight rule and the confusion of inpatient and outpatient, RAC started auditing medical necessity of care. So what CMS told all 4 contractors across the country is to follow the 2 midnight rule, audit cases based on that, as well as medical necessity. Now, once that happened, that opened up a huge Pandora's box of auditing. They decided to audit documentation, coverage, procedures, imaging. And right now, when hospitals started to fight back against these audits, appeals backlogged. As of the time of this presentation in December 2016, there are about 800,000 appeals that are pending to be adjudicated by administrative law judges, for a total value of $4.6 billion that are on hold. Hospitals do not have that money. CMS started to introduce new incentives, which are value-based, and I'm sure a lot of you have heard about the MACRA and the MIPS. MACRA is the Medicare Access and CHIP Reauthorization Act, signed into law April of 2015, that introduced some payment systems called the MIPS, or the Merit-Based Incentive Payment System, and the Alternative Payment System. Now, in addition, next generation accountable care organizations, comprehensive primary care plus programs, and then chronic care management programs. Now, chronic care management was to incentivize hospitals so that when readmissions happen within 30 days of a chronic condition like CHF or COPD, they would be bundled as one. And so readmission penalties started coming onto hospitals. In addition, they introduced the timelines for the MACRA MIPS APM payment models, where 2017 would be base payment year, and then as we go onwards till 2022, hospitals could either lose or gain 4, 5, or 9% based on how they compared with their peers and on metrics that CMS released. Now, on the other spectrum, insurance companies have already they've always had auditors. Their auditors are incentivized to find different targets. And what are they looking for? Well, similar stuff. But what they look at is misrepresentation by the physician, whether there's a false coding or a false service which comes under the EM audits. Unnecessary care, again, comes back to medical necessity of care. Altering medical records, late entry into records, delay in care, and then physician office errors that they found are very common sources of billing errors. In addition, they do follow the 2 midnight rule. They also follow what CMS follows as documentation, coverage, procedures, and imaging, and mainly based on whether these are even necessary for the patient. CMS and private insurance companies have a very good relationship. CMS contracts with the private insurance group to provide care to the hospital, to patient or Medicare beneficiaries in the form of Medicare Advantage plans. Hospitals have their own conditions of participation with CMS based on the Medicare Beneficiary Provider Manual. In addition, hospitals have condition of participation agreements with the insurance companies. And so all these are interrelated, and at some point, an 80-year-old patient who has Medicare may be interpolated or bridged into all three systems. Insurance companies have relationships with their beneficiaries in terms of what their benefits are, and that's what determines what sort of care that they can get. Now, CMS and insurance companies have started thinking outside the box, which is population health. And so you have been hearing a lot of value-based care, population health. What this is putting an additional burden to the hospitals in terms of reporting, whether it's claim-based reporting, registry reporting, or EHR reporting. So the 2014 PQRS reporting that hospitals and physicians needed to do are now almost consolidated into what MACRA and the MIPS and APM requirements are. So there's a lot of administrative burden that's coming onto hospitals, which has sadly left a lot of rural hospital closures in the last 5 years. While we know on the other spectrum, these multi-billion-dollar mergers between insurance companies, one, either to provide better population health care, better analytics to find out which are the sickest patients, and at the same time decrease their own overheads. That has led to a tremendous increase in premiums for patients who actually end up being the sole loser. I think what the whole purpose of this short discussion is to stimulate some thought process on whatever we do as healthcare leaders. We need to make it patient-centric, and so we could find common ground between providers, hospitals, CMS, and insurance companies. This is Healthcare Auditing Basics in one slide in a nutshell. Thanks.